Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 576 of our pharmacotherapy series, which majors in geriatric drug use. The first case reads, JOW is a married woman, with a height 5 feet 8 inches, a weight of 110 pounds, and is 79-year-old. She presents for a psychiatric evaluation. Her husband says she just has not been herself lately. The changes in JOW began on a family vacation 6 months earlier when she got lost on the cruise ship. Since that incident, she has become increasingly anxious and has developed insomnia. Although she does not feel sad or depressed, she generally does not feel well. JOW's normally positive attitude toward life has become pessimistic. Her husband confirms that she has become more forgetful and no longer enjoys eating. In fact, she has lost 18 pounds during the past 2 months. JOW no longer does her volunteer work at the local children's center. She says she wants to die because she is no longer the person she used to be, but she denies having any specific suicidal thoughts. Her medical history is significant for diabetes and hypertension, which are both well controlled on G-lipotide 5 mg every morning and hydrochlorothiazide 25 mg daily. Her medical evaluation and physical examination are unremarkable. Laboratory results and head-computed tomography scan are within normal limits. JOW is diagnosed as having a major depressive episode. So my next question to you reads, what symptoms of depression are present in JOW? JOW's presenting symptoms are typical of major depression in an older patient, which is commonly quite different from that of younger depressed patients. Criteria set forth in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, for diagnosing depression were developed using younger subjects and may not be applicable to the older depressed patient. Older patients are less likely to report suicidal thoughts, but are more likely to experience weight loss as a symptom of depression. Anxiety, irritability, somatic complaints, or a withdrawal from normal activities, as exhibited by JOW, may be more significant features in late-life depression than depressed mood. Memory problems, such as JOW's forgetfulness, may be attributable to a lack of concentration or effort stemming from her depression. This is distinct from dementia, which manifests itself predominantly with impairment in short and long-term memory. Therefore, depressed mood cannot be relied on for determining whether an older patient has a depressive disorder. The presence of any one of these symptoms should be considered a red flag and should prompt further evaluation for major depression. JOW's physician decides to prescribe an antidepressant. My next question to you reads: which antidepressants are preferred for use in older adults? Selection of an antidepressant drug for elderly patients must take into consideration age-related changes in pharmacokinetic, pharmacodynamic, and physiologic parameters that make this population more vulnerable to adverse effects. Although the available antidepressants are equally effective, selective serotonin reuptake inhibitors, abbreviated as SSRIs, are better tolerated than older agents, such as the tricyclic antidepressants. Therefore, low-dose selective serotonin reuptake inhibitors should be considered first-line therapy for older patients. Of course, this does not preclude the use of sound clinical judgment that incorporates the patient's history of response, comorbidities, and the drug's side effect profile. JOW should start taking a low-dose selective serotonin reuptake inhibitor, such as citalopram 10 mg daily, with gradual dose titration to achieve control of her depressive symptoms. Doses of citalopram should not exceed 20 mg per day in adults over age 60 due to risk of QTc prolongation. Full antidepressant response may take twice as long in older patients compared with younger patients. It may take 8 to 12 weeks before assessment of JOW's full response can be made. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 577.